Alrighty, this is Dr. Gardner, and I will be lecturing on the gastrointestinal system. Here are some of the objectives that I hope to cover, and I'll let you read those for yourself. And this is covering Chapter 17 and Chapter 36. So some of the medication that we will talk about will be antacids, anti-diarrheals, the cytoprotective drugs. I'll go over antiemetics, the H2 receptor antagonists, proton pump inhibitors, and laxatives. I will not be covering prokinetics in this lecture due to time. Okay, so we'll start off with antacids. So they neutralize the acids in the GI tract. There's different combinations that have differing acid neutralizing capacities, like the sodium bicarb and calcium carbonate. Those are the highest acid neutralizing capacity. Want to go over pharmacokinetics. Why are we going to go over pharmacokinetics? Well, let's think about your patient. So aluminum and magnesium, those are not absorbed with normal use, and they're excreted by the kidneys. And I'll go over this in a second. Calcium-containing antacids, they require vitamin D for absorption, and they're excreted in the feces. But why are pharmacokinetics important to know? Think about a patient with renal insufficiency. When drugs are excreted by the kidneys, but the patient has renal insufficiency, what kind of complications can they have? What would you be monitoring this patient for? This is how I want you to think about pharmacokinetics and the importance of learning it related to patient situations. When you think of renal insufficiency and you think of patients on dialysis or elderly patients, what kind of complications can they have if you're prescribing them a medication that's excreted by the kidneys, but they have renal insufficiency? So some of the precautions and contraindications would be abdominal pain. Here we go with calcium-based antacids. They're contraindicated in patients who are hyperkalemic or has renal calculi. Stones. Why is that? Magnesium-based antacids. They're contraindicated in patients, again, with renal failure or renal insufficiency. Why? Aluminum-based antacids should not be used in patients with renal failure on dialysis. And if there's a high sodium content, what about patients with CHF, hypertension, and renal failure? So let's consider the precautions. Put on your thinking cap. How are aluminum and magnesium-based antacids excreted? In the kidneys, right? So someone with renal insufficiency can't excrete those medications the same as someone with normal kidney function. So this may cause a patient to develop like neurotoxicity. And why is that? What's causing this? Is it maybe the hypermagnesia because they're not excreting it? So that magnesium is building up in their system? That's how I want you to think. Okay, some of the common adverse drug reactions of the antacids. Well, we have the diarrhea. That's for the magnesium based. We have constipation from the calcium and aluminum antacids. And let's see. How are we going to administer? Separate administration by at least 2 hours. And be careful because these drugs affect the absorption of most drugs. Okay, we'll go into the uses and dosing. So, heartburn. How would you dose an antacid for a patient with heartburn? Well, 4 times a day or more. If they have peptic ulcer disease, that's an adjunct, or you may be using triple therapy. You're going to give that to them after meals and at bedtime. For gastroesophageal reflux disease, or GERD, antacids over the counters are usually the first use. And those are 30 to 60 minutes until symptoms subside for acute cases, and then for maintenance, after meals and bedtime. The H2 receptor antagonists, or PPIs, they're first line therapy. And you have, let's see, we'll talk about the calcium deficiency and osteoporosis prevention. You can also use antacids for those. So when you're going to educate your patient, what are you going to educate them on? Well, they need to let you know if they're taking antacids for longer than 2 weeks. They need to let you know if they have any symptoms of GI bleeding. If they have constipation, they can take a stool softener. If they have diarrhea, let them know about lifestyle changes they can make too. Stop smoking. Elevate the head of the bed when they sleep, at least 15 degrees or more. Sit up for about 30 minutes after meals. Avoid spicy foods. Limit or avoid alcohol. Avoid those fatty foods and those chocolate. Everybody loves chocolate. But if you have stomach problems, you really need to avoid chocolate and you need to avoid caffeine. Okay, what's the rationale drug selection? Well, combination products have the highest acid neutralizing capacity. Sodium content. Maybe they need sodium and you can increase their sodium. Cost. These can be purchased over the counter. They're relatively inexpensive and you can get them in generics. Now think about monitoring as well when you're selecting the drug. Think about the magnesium level in the elderly population. Okay, we're going to move on to anti-diarrheals. Some causes of diarrhea, infections, could be food, could be medication, just could be inflammatory bowel disease. There's acute diarrhea versus chronic diarrhea. In children, when they have diarrhea, you want to monitor for dehydration. And medication is usually not even required. So let's talk about the preparations. There's absorbent, which is the kaolin and pectin, or the bismuth. There's the opiates, and there's anticholinergics. Absorbent preparations, they can be used safely in patients with infectious diarrhea. Bismuth, that's an anti-secretory and it has antimicrobial effects. Loperamide, that binds to opioid receptors and slows gastric motility. So the opioid agents are all absorbed and distributed systemically. They're metabolized in the liver and they're eliminated in the urine or the feces. So let's talk about some of the precautions and contraindications. Well, opioids decrease intestinal motility, which may cause toxic megacolon. Bismuth, again, is contraindicated in children if they have a viral or flu-like illness. There we go. Use cautiously in our older population, our older adults. It's contraindicated in the treatment of diarrhea in most children. Monitor patients that are taking laxatives for pancreatitis. And allosterone has a boxed warning and it's contraindicated in patients with constipation. Anti-diarrheals, some of the common adverse drug reactions, it can cause constipation. It can also cause black tongue or gray-black stools. If you prescribe the opioid version, they may have dizziness, drowsiness, sedation, or headache. Some of the drug-drug interactions, the diphenoloxate and diphenixin with atropine have some anticholinergic effects. So let's talk about the uses and the dosing. So for acute diarrhea, first of all, treat the source. It's used for in bowel disease, chronic infantile diarrhea, traveler's diarrhea, IBS. Some patients taking the HIV antiretroviral drugs. Maintain hydration for patients using anti-diarrheals. For absorbents like the kaolin pectin or the bismuth, that's used after each loose stool to maintain hydration. Also, when you're trying to maintain hydration, make sure you're maintaining electrolytes, giving some kind of electrolyte solution in infants and young children. You can use like just flat soda or water to maintain hydration in adults. For bowel disease, the loperamide is used 4 times a day, and that can be used as an adjunct therapy. For chronic infantile diarrhea, we use the bismuth. For traveler's diarrhea, we use bismuth subsistolate with each meal and at bedtime to prevent it. So if they develop it, then you use the bismuth subsistolate every 30 minutes for up to 48 hours with a max of 8 doses. Loperamide is 4 milligrams, then 2 milligrams after every stool. For irritable bowel syndrome, we use the ulixacillin or loperamide. Allosterone in women with severe IBS that's not responsive to other treatments. Okay, so rational drug selection. Any anti-diarrheal can be used for acute diarrhea in adults. Bismuth subsistolate and loperamide are used for traveler's diarrhea, and the cost. It's inexpensive for the most part, and they have generics, and you can purchase them over the counter. There's some that are prescription only, but for the most part, they can get these over the counter. So you want to warn your patients about rebound constipation. You want them to know about the bismuth turning the tongue or the stool black. You want to warn them about dry mouth, some of the central nervous system effects, and you want to tell them about, this could possibly cause pancreatitis. That's the fluoxetine that may cause pancreatitis. And of course, you want them to know that they have to hydrate. Hydrate, 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 hydrate. Okay, so some of the rest of this unit, I'm just going to summarize some of these topics because I know your brains are in information overload. So let's hit the highlights. So cytoprotective agents. That is carafate. It binds to ulcer tissue and it acts as a barrier. There's also Cytoprotective, which inhibits gastric secretions, and it has a mucosal protective qualities. Precautions. Category X for misoprostol. If anybody has any labor and delivery experience, you know what Cytotec is used for. So that is a category X. It is, the clinical uses would be, wait, hold on, I want to go back. Let's see, how do I go back to that? Let's see, can I go back? Oh, wait. Let's see, how do I go back to that other slide? Okay, here we are. Sorry. Okay, so clinical uses would be, oh, I'm doing it again. Okay. Ulcers associated with NSAIDs, duodenal ulcers from other causes, the ADRs, adverse drug reactions. Carafate may cause constipation, misoprostol, diarrhea, and menstrual problems. Carafate decreases absorption of other drugs, and misoprostol causes diarrhea with magnesium-containing antacids. Ulcers associated with NSAIDs is the first choice is to stop the NSAID. Use misoprostol if patient requires NSAID therapy. You dose that 4 times a day. Women of childbearing age need a pregnancy test. Why? I discussed it. Put your thinking cap on. For duodenal ulcers, carafate can be used for up to 8 weeks to heal an ulcer. It's given 4 times a day, which is 1 hour before meals. And it can also be used for gastric ulcer progression. Okay, we're going to move on to antiemetics. There's different classes of antiemetics. You'll read them there. Some of the precautions or contraindications is they may mask an ileus. Promethazine, that can cause fatal respiratory depression in children younger than 2 years of age. So we use it for symptom relief of nausea and vomiting, prevention of fluid and electrolyte disturbances, so they can aid in hydration, because if they're throwing up, vomiting, they're going to get dehydrated. So we give them this to maintain hydration. Also maintain electrolyte balance with replacement solutions. So a little bit about cannabinoids. They work in the CNS to prevent nausea and vomiting, and associated with cancer chemotherapy. One of the anticholinergics is scopolamine. That is can be given transdermal behind the ear. It's really good if someone's going on a cruise, and you'll tell them to put that on prior to getting on the ship. Some patients, if they don't get proper education, put it on when it's too late and it won't work. So some of the precautions and contraindications of antihistamines, they have the anticholinergic properties. Like the phenothiazines, they can produce extrapyramidal symptoms, EPS. So they're contraindicated in a patient who has Parkinson's. Think about why they're contraindicated in that patient. Dronabinol, use that in caution with patients with seizure disorders. The 5-HT3 receptor antagonists may mask the ileus, like I said earlier. Antihistamines can cause drowsiness, dry mouth, blurred vision, urinary retention. Those are those anticholinergic effects. The phenothiazines can cause drowsiness or the EPS, such as dystonia, akathisia, and tardive dyskinesia, which you'll learn a little bit more about in the um, psych area. Cannabinoid dronabinol, that can cause like a euphoria. It may cause a depression, may cause dizziness, paranoid thoughts, somnolence, and abnormal thoughts. And you want to know if you're going to prescribe a can cannabinoid dronabinol, you need to know what effects it causes and who you can and cannot prescribe this to. The H2RAs, they are reversible competitive blockers of histamine, H2 receptors. The ranitidine is 5 to 12 times more potent than cimetidine, and famotidine is 30 to 60 times more potent. It's a category B, and ranitidine and famotidine use is approved in children. Be careful of agranulocytosis, thrombocytopenia, aplastic anemia, granulocytopenia. Those are some very big guns that you have to monitor for. Drug interactions, cimetidine inhibits the cytochrome P450 enzymes in the liver. Used for sour stomach. They will take these with meals, separating acids by 30 minutes to an hour. Cimetidine may cause gynecomastia and impotence in men. Smokers need to know that smoking decreases the absorption of H2RAs. And alcohol increase gastric irritation, so they need to avoid the use of alcohol as well. So we move on to proton pump inhibitors, or PPIs. They treat gastric conditions characterized by hyperacidity. It's metabolized by the liver. It's a pregnancy category B or C, so use with caution. Do the benefits outweigh the risks? Pantoprazole is not approved in children 5 years of age and younger. And rabeprazole is not approved in children less than 12 years of age. Big contraindication. If they're on Plavix, there is a black box warning regarding the interactions of Plavix and omeprazole. Also, this may mask symptoms of gastric cancer. PPIs are used for duodenal and gastric ulcers and GERD. Some of the adverse drug reactions, they have a risk for nutrient deficiencies like iron, vitamin B12, and calcium. Long-term use of PPIs increases the risk of osteoporosis and hip fractures. It also can increase the risk of C. diff, salmonella, and campylobacter infections. Can increase the risk of pneumonia. There is a questionable gastric cancer risk with PPIs. Let's see. PPIs are combined with antibiotics to treat H. pylori. When it's used for GERD, you may see patients, when you start practicing, you may see patients that have been on this for months, for years, but the approved use is for 8 weeks, and then the patient must be tapered off. And you may need to double the dose for 4 weeks and then decrease the dose for another 4 weeks. When you're titrating this medication or tapering them off of the medication, you want to decrease from twice a day to once a day, then every other day, with an H2 receptor antagonist used for symptoms, and then the patient is weaned off. Laxatives. There are 6 different classes. Review your notes for those classes. All are contraindicated in the presence of nausea, vomiting, undiagnosed abdominal pain, or if bowel obstruction is suspected or diagnosed. Thinking cap time. Magnesium hydroxide is contraindicated in renal dysfunction. Put your thinking cap on. Why is that? And methyl naltrexone may cause opioid withdrawal. So some of the, oh wait, I have one more thing. Nope, gotta go back. Okay. So some of the uses in patient education would be bloating, cramping, flatulence. Rapid response should be used for short-term stimulants are the drug of choice. And bulk forming is safest in pregnancy, like Miralax. If you give rapid acting, they're best taken in the morning, and slower action are best taken at night. Okay, we are almost done with this one. Let's go over some of the key takeaways. This is your verbal blueprint. Understand renal insufficiency for all of the drug categories. Know how to treat gastric ulcers. Know the advantages and disadvantages of different medication classes. What is safe or unsafe in pregnancy? What is safe to treat children? And what age can you treat with different medications? Think safety. When you are prescribing, you have to understand major complications from different medications. So you have to know, before you prescribe this medication, what should you be looking for? Or after you've prescribed it, what should you be looking for? You will need your thinking cap. Listen carefully to the lectures, but do not memorize. To prescribe, you must understand. Think in terms of you prescribing a medication in each class. What are some things you may need to know about the patient? What are some complications you might look for when you prescribe one of the medications? All right, that is it. You have one more lecture that you will probably receive later this evening or tonight. That's all, folks.